Hello everyone, so today we'll be looking at a case study. It's an actual case that I saw in ward. But before we look at the case, let's have a quick recap of what are alarms symptoms. Let me give you a hint. Every single letter in alarms and the S in symptoms stands for something. Have a pause of the video and have a think about it. Alright, and now I want you to think about how do you use these alarm symptoms in your clinical evaluation. Have a pause of the video and have a think about it. Alright, here comes the answers. So alarms stands for, A stands for anemia, L stands for loss of weight, A stands for anorexia or loss of appetite, R stands for recent onset of progressive symptoms, M stands for melena or hematemesis, and the S in symptoms stands for swallowing difficulty or dysphagia. And how do you use this? Basically, it gives you a general guide. When you think about alarms, think about urgent OGDS, right? So, according to the Oxford Handbook of Clinical Medicine, they say if a patient presents with alarms symptoms with treatment refractory dyspepsia, send them for urgent OGDS. If a patient presents with alarms with age more than 55, send them for urgent OGDS. And if the patient presents with only the S in alarms, S stands for swallowing difficulty, only dysphagia, also send them for urgent OGDS. And urgent OGDS meaning, the keyword urgent, meaning probably you want to send them within 1 to 2 weeks, not 3 to 4 months, as it will be a bit too late. You're suspecting malignancy, right? Loss of weight, loss of appetite. You're thinking of malignancy. Cancer, you gotta do it fast before it spreads. Treat it fast before it spreads. Right, let's look at the case itself. So, Incheck M is a 70-year-old Malay male who is an ex-smoker with underlying diabetes and hypertension, presenting with epigastric pain for 4 months, worsening over the past 1 week, and also history of multiple visits to Klinik Kesihatan and Hospital Kota Tinggi for a similar complaint, discharged with syrup MMT, pantoprazole, and analgesia. You also see that he has a TCA in our SFUC clinic HSI for OGDS in 2 months. Loss of weight of 9 kg in the last 3 months, and loss of appetite to the extent that he's only tolerating Nestum for the past 1 week. And investigations as follows. So, can you tell me what are the significant histories listed here? Relate back to your alarms, symptoms. Right, pause the video, think about it. You look at, okay, think about alarms, age more than 55. Is he more than 55? Yes, he's 70 years old, more than 55. Alarms plus treatment refractory dyspepsia. Does he have that? Yes. History of multiple visits to KK and HKT for the similar complaint. Why do you think he went to the KK and HKT so many times? Because it was not responding well to the treatment refractory. And alarms itself. A stands for anemia, HP of 8.7, normal range, probably for male around 13 to 15. This is low HP. L stands for loss of weight, significant loss of weight here. A, second A stands for anorexia or loss of appetite. It's there. If you think about it, almost everything in alarms is there. R stands for recent onset of progressive symptoms. Epigastric pain for the past 4 months, worsening over the past 1 week. That's recent onset of progressive symptoms over there. M stands for melena or hematemesis. You're right, I missed it out here. If you ask me what's the parectal examination findings for this patient, it was brown stools. So no melena and no hematemesis as well. How about S in alarms? Stands for swallowing difficulty or dysphagia. Funny, right? He doesn't have dysphagia. in the ED document, it was documented no dysphagia. When I asked him, do you have any swallowing difficulty? He said no. But our topic here is dysphagia. Does he really not have dysphagia? It's actually more that meets the eye, as we'll see later. Right, here are the answers, which you can refer to later. I'll be sending you the slides. And something else I want to highlight is that he was only tolerating Nestum for the past 1 week. At first, when I clerked this patient and he told me this, I was thinking, oh, this is more of the severity of the loss of appetite. No selera to makan solid food. So, drinking Nestum for the past 1 week. However, if you think about it, if you know that this patient has dysphagia, you would think of it in another angle, where if this patient is tolerating Nestum, which is a liquid, better than solid foods, it would point towards a structural etiology of dysphagia, structural cause of dysphagia, right? Just something to think about. Right, so after taking a complete history, we move on to physical examination. Wait, kind of forgot. Alarms, urgent OGDS, right? Yeah, so what you want to do with this patient, so many alarm symptoms. You want to do an urgent OGDS. But before that, we do an examination first, physical examination. So on physical examination, for the abdomen, he is very, very tender over the epigastric region, left hypochondrial region, also left lumbar region, these 3 areas. Very, very tender. And this might be subjective, but feels like there's some fluctuant or feels like air underneath. Sort of like feeling like some subcutaneous emphysema or something there. So, specialist number 1 and MO number 1 reviewed this patient because it was so tender, they were suspecting gastric perforation. So, what they asked me to do was to insert an NG tube for this patient and pump 200 cc air into the stomach. We want to look for, do a chest x-ray erect, make sure it's erect. He asked me to follow the patient down and make sure really it's erect, chest x-ray. So, they're looking for, actually, air under the diaphragm. If there's perforated gastric ulcer, PGU, this patient would have air under the diaphragm. However, chest x-ray, after putting in the NG tube, pumping 200 cc air into the NG tube and sending the patient down, chest x-ray showed gastric bubble, no air under the diaphragm. So, no perforated gastric ulcer. However, if you see carefully here, you can see some lymph nodes over here. 3 lymph nodes here, one big one here. And some patchy consolidations. However, clinically, lungs were clear. No difficulty breathing, SpO2 99% in the room air. Not pneumonia, although he's an ex-smoker. Right. Moving on. It was a weekend, so nothing much else was done on that day. Planned for OGDS on Monday. Next day, the patient, specialist number 2, reviewed the patient and asked, does this patient have dysphagia? I said, no. Are you sure? The specialist asked the patient to drink a cup of water. And during observation, you observe them drinking that cup of water, that glass of water. You can see that he has actually some difficulty swallowing the water. It looks like he needs increased effort, he needs increased pressure to push the water down. So, learning point here is, even if they say they don't have dysphagia, on examination you can ask them to drink a glass of water and you can observe whether they have dysphagia or not. Right. Okay, so this patient seems to have dysphagia, and if you ask him directly, he actually has some retrosternal discomfort when he's swallowing. And how is that important? Where the location of the dysphagia is retrosternal. So a dysphagia approach to dysphagia, you have structural causes and motility causes. We saw that this is more of a structural cause because tolerating liquids better than solids. And now we're thinking, is it oropharyngeal dysphagia or esophageal dysphagia? And the location of this discomfort is retrosternal. So this is esophageal dysphagia. Right. Applying our knowledge from previously. Okay. And on general inspection, you can see that this patient is cachexic. And there's some special examination that the specialist number 2 did for this patient. Is she hold the pelvis of this patient and shook it and try and hear for something known as the succussion splash. Succussion splash was not present, right? And also if you look at the neck here, there's some enlarged lymph node over here. What's that? Troisius node. This is a sign of GI malignancy. For this patient, it was not visible like this. It was only slightly palpable 1 × 1 cm over the left supraclavicular area. It's hard inconsistency. It was not visible, however it was there. Okay, Troisius node. Right? I think I said all this. Ask to swallow glass of water. Observe the need increase effort, increase swallowing pressure. Slight retrosternal discomfort. Cachexic looking. Soft non-tender over epigastric and left hypochondrial region. No guarding, no mass palpable. No evidence of succussion splash. What are you looking for? Troisius node pula. Virchow's node. Remember the name wrongly. Sorry. It's Virchow's node. Virchow or Virchow. No evidence of succussion splash. What are you looking for in succussion splash actually? You're looking for gastric outlet obstruction. Right. In this case, there's no. Also, there's left supraclavicular lymph node, Virchow's nodes, palpable 1 × 1 cm, hard inconsistency. Further history, he also has early satiety for the past 3 weeks. And how is this relevant? You are thinking about another differential. Early satiety means there's something inside the stomach. Early satiety means you feel full really fast. Eat a little bit, then you feel full already. Reason being, there might be some mass in the stomach or some mass pushing against the stomach, which causes the stomach to fill up even with small amount of food. So yeah, you're thinking about gastric cancer as your differential. A mass in the gastric area. So now, through further physical examination, we know that this patient actually has dysphagia. And this specialist number 2 was highly suspecting an esophageal pathology and something that is pointing towards cancer. The cachexia, the loss of weight, loss of appetite, and the Virchow's node pointing towards GI malignancy. So remember, we want to do an urgent OGDS for this patient. Next day, the patient went for an OGDS, but before that, the specialist warned that you have to be careful when, especially during insertion of the scope. You insert too fast, it might perforate. So, and this risk was explained to the patient and the patient's son. High risk of esophageal perforation during OGDS. And during the OGDS, my heart just kind of sank. Look at how bad it was. These are real pictures I took. It's circumferential, it's fungating, it's bleeding, it's friable. Endoscopic findings: esophageal tumor starting from 15 cm from incisor to 2 cm below the cardia. It's a long segment tumor, circumferential, fungating. I would add friable, bleeding to touch. Able to pass through the scope through the stomach. The stomach was normal. Duodenal polyp at D1, benign looking. Is the polyp, 5 mm. And by right, the biopsy should have been taken. OGDS guided, and GT was placed. So, looking at these pictures, although no HPE yet, tell me it's anything other than esophageal cancer. You know, that's the top of your differential, esophageal cancer. So let's have a look a bit about esophageal cancer. Epidemiology is the 8th most common cancer worldwide. It's the 6th most common cause of death worldwide. 90% HPE comes out as squamous cell carcinoma. However, the trend is changing, especially in the more advanced countries. Adenocarcinoma is increasing in trend compared to squamous cell carcinoma. Used to be squamous cell carcinoma is the most common because of how prevalent smoking was, and then now because of another etiology, which is good, causing Barrett's esophagus, causing metaplasia, then dysplasia, then metastasis. So risk factors depend on the different cell types. If it's a squamous cell carcinoma, risk factors for these are smoking and alcohol. If it's an adenocarcinoma, risk factors for this are smoking and high BMI and GERD. So smoking contributes both ways. Smoking also relaxes the lower esophageal sphincter, causing GERD and then causing Barrett's esophagus. You see, this is a picture of a normal Z line. You can see Barrett's esophagus is the metaplasia of the squamous cell into into what cells are these? Glandular cells, right? And also another risk factor is bisphosphonates, which is a medication used for osteoporosis. Remember, one of the medications which you need to make sure the patient sits up while eating this medication is alendronate, because it causes irritation of the esophageal lining, causes irritation, pill esophagitis. You can see streaks of inflammation when you do the scope. Right. And the post-OGDS plan, strictly nil orally. All oral medications to be served crushed via rice tube, because we are afraid of the risk of esophageal perforation. And for upper GI to take over, was referred to upper GI team on the spot in the scope room. Start 2 scoops glucina, start feeding, but watch out for refeeding syndrome. IV drip 3 pint over 24 hours. Referred. And private ambulance was arranged because no ambulance available. Right. You see how urgent it was. And then treatment. We can't really, I couldn't really track what happened to this patient because he was sent over to HSA. However, the next best thing look at is study lah. What are the treatment options available? This is from Up to Date. So it says that treatment heavily depends on accurate staging. Accurate staging is vital. So here you want to recap a bit about the anatomy of the esophagus. There are a few layers, and the deeper it is, the higher the staging. So T1A, the tumor invades the first layer, lamina propria or the mucosa. T1B, tumor invades the submucosa, this layer here. T2, tumor invades the muscularis propria, this layer here. And T3, tumor invades the adventitia, which is the outermost layer here. And in the minority of patients, the disease is only limited to T1A and T1B. In these patients, surgical intervention has high cure rate for these patients. However, if the patient is T3 or above, or not positive, combined radiochemotherapy is preferred over surgery alone. So, staging vital, right? However, if you notice, T2 is not written here. So, it's actually in the gray area. So, some guidelines suggest initially you want to resect, other guidelines suggest chemoradiotherapy first. T2, gray area. However, sadly, most patients present with incurable, locally advanced, unresectable, or metastatic disease, about 50 to 80%, which is a lot. And the criteria for unresectability, how do you know? Also, the staging. So potentially resectable is T4A, where the tumor invades the pleura, pericardium, azygos vein, diaphragm, or peritoneum. It's still potentially resectable, but it becomes totally unresectable when there is metastasis, M1, or T4B and above. T4B is the most. So tumor invades other adjacent structures, for example, the aorta, the vertebral body, and the airway. So the learning point is accurate clinical staging, both local tumor extent, which is the T staging in TNM staging, and presence or absence of distant metastasis, which is the M, is critical for estimating the prognosis and deciding the direction of treatment. Right? Is it a curative or is it a palliative? Because if it's incurable, you don't want to go too aggressively. You want to improve quality of life. Okay, so local regional staging, which is the T staging, T in TNM, you use EUS. The main investigation is EUS, endoscopic ultrasound. And in EUS, this example image, you can see the tumor here. It's probably T1, T2, T1A, T2, T1A or T1B, this patient, right? I'm no expert, but here, and then for presence or absence of distant metastasis, you're going to do a CT-TAP, or even better, FDG PET scan, fluorodeoxyglucose PET scan, combined with a CT-TAP. The PET scan is to see where are the glucose uptake, and then the CT part of it shows you the anatomy. So you combine these two, you get a very good image on the areas that they metastasize to. This is the FDG PET. This combined with CT. So you can see already metastasized to the vertebral body. You can see already metastasized a lot to the liver, the spleen, etc. You see the brain is also hyperactive, but doesn't mean that it has metastasized the brain. It just means that the brain uses your glucose as energy. Right. So if it's still resectable, we go for surgical intervention. Depends on the anatomy as well. If it's higher up, which is a cervical. If it's T1N0 M0, which is the early disease, esophagectomy is the first line. And there's a picture of esophagectomy. You take out the esophagus. But it also depends on the location of the cancer. If it's at the cervical area, chemoradiotherapy is more suitable. But for those who fail chemoradiotherapy, surgical option is also available, but it requires removal of portions of the pharynx, larynx, and thyroid gland. And then esophageal cancer involving the middle third or lower third of the esophagus. Total thoracic esophagectomy is the option because there is a risk of submucosal skip lesions, so you might miss. So you take out the whole thing. The first line, esophagectomy. Let's say this patient is already T4B and above, already have metastasis. Then you treat palliatively. Let's say this patient has dysphagia, you treat the dysphagia. And for dysphagia, it responds very well to chemoradiotherapy. However, it takes time, and not everybody is fit for chemoradiotherapy. If you're ECOG 3, probably not so fit for chemo. Or not everybody can tolerate, and also it takes time. It takes about 4 weeks, at least 4 weeks, for the improvement in dysphagia. So meanwhile, you can do surgical or endoscopic options, which I'll talk about. So you have endoscopic stenting with SEMS, or self-expandable metallic stents. I've seen one of these done by our gastro specialist. It's actually kind of impressive. He used one of these stents to do a gastroduodenostomy because of some mass obstructing the duodenum. Gastrojejunostomy, first in JB. I saw they use this stent. Other endoscopic options for palliation of dysphagia include photodynamic therapy, use of photosensitizing agent plus low power laser to cauterize it, laser it, or argon plasma coagulation is a non-touch also, using monopolar non-contact high frequency electrocautery using argon gas. Also, other options include cryospray ablation, cryotherapy, which is using liquid nitrogen to freeze it, and esophageal dilation with balloons, either through the scope balloon or wire guided polyvinyl boogies. This is a treatment for esophageal strictures as well. Need to put a scope in, guide a wire through it, and inflate the balloon, make the space bigger. Right, that's all I have for you. Hope you learned something. Maybe the treatment part is a little bit too advanced, but the approach part is what you need to take home. Right, thank you for watching, and hope you learned something.